Okay, I think you can get started so we don't lose much time. And yeah, people will still be joining,
Okay.
perhaps.
Mhm.
Yes, thank you.
Perfect. Thank you. Well, thank you all so much for joining today. My name is Shelby. I am a nurse practitioner at Children's National in Washington, D.C. Um, and today we're going to discuss a little bit of a QI project that we did here to try and decrease propofol exposure and time under anesthesia for our leukemia patients getting routine lumbar punctures. I worked on this project in conjunction with the rest of my sort of non-operating anesthesia room team. Um, Dr. Wistinghausen, Dr. Vaughn's, Lisa D'Angelo, our OR nurse, and of course, one of our wonderful fellows, Alyssa Goiser. So first off, why is this important? So Children's Oncology Group did a study a number of years ago that proved, in terms of sort of processing speed and reaction times, that we know that higher cumulative doses of propofol over the course of treatment are independently associated with worse neurocognitive outcomes. And that we did see impairment in processing time as well as abnormalities on imaging. And so, as this has become more well known, it is something that a lot of our families are concerned about routinely and sort of often ask, what are the long-term side effects? What are you all doing to mitigate them? So it made us think, now that we know this outcome, how can we try and improve those side effects? So we decided to take a look at general anesthesia time for these patients. So we are fortunate enough here that we have a mini sort of operating room in our hematology oncology unit, that we have a certain set of anesthesiologists. There's about 10 to 15 that rotate through. And we had sort of a pretty easy access to start and stop times for anesthesia for all of our patients that we do lumbar punctures in that procedure room for. And so we wanted to establish a baseline. If we pulled those average anesthesia times, what were the common variables that impacted anesthesia time? To be honest, I think a lot of us assumed it would be age, it would be weight. Are they more difficult lumbar punctures? Is it a more experienced proceduralist, such as, an NP or a PA who has been around for a while, or a fellow? And interestingly enough, none of the things that we thought were going to impact the procedure time did. So the status of the patient, whether the proceduralist was experienced or not, really didn't seem to impact anesthesia time in any statistically significant way. But what did was the anesthesiologist on the case. Um, and so that caused us to sort of take a step back, speak with the anesthesiologist, and look at what are the ones that have these ideal times, these faster times, doing differently from those that have longer anesthesia times. Um, and sort of after chatting with them and sort of looking at the different variables, we decided to sort of pull them together and decide that we were going to try and increase the percentage of patients undergoing lumbar punctures in NORA receiving propofol to under 15 minutes. And we wanted to increase that percentage of anesthesia time under 15 minutes from 48% to 75%. And in looking at sort of the different variables, we thought that with a little bit of attention to detail, this would be an achievable goal. And so, like I said, the main difference was the anesthesiologist on the case. And what we found was that the anesthesiologists that were in good communication with the proceduralists knew if they were ready to start, knew that everything was set up, knew when the procedure was complete, that communication and that attention to detail in terms of start and stop time of anesthesia really did seem to make the biggest difference. And so we came up with um, a sort of workflow for the procedure room that we wanted everybody to stand by. So prior to anybody being in the room, the anesthesiologist, in conjunction with their nurse, got everything set up. The propofol infusions were ready to go. Their supplies were ready to go. And then the proceduralist was to set up their kit, make sure they had their chemo ready, their, antiseptic, their gloves, that everything was all um, sort of teed up and ready to go. and that the anesthesiologist and the procedure team would then both agree, okay, we're set up, we're complete, we're ready to go. And then we would bring the patient back. Once the patient was in the room, we would get the patient sort of in the general position, put the leads on, get all of our monitoring equipment up and running, make sure that the procedure team was again ready to go, had already identified the patient, identified the chemo, was scanned out correctly. And then when everyone says ready to start, the anesthesiologist would say, okay, we're ready to start propofol. Procedure team would confirm, and the anesthesiologist would start the propofol. We would then go ahead and have the procedure team perform the lumbar puncture, collect the CSF, and then as they're injecting the chemotherapy, saying injecting chemotherapy as a cue to the anesthesiologist to, okay, we're basically done. We're going to stop and discontinue the propofol. And so this intervention, we looked at data from the past year prior to this past August. And then sort of between August and September, we educated our providers. We put the posters of the previous slides up in the procedure room and really made a concerted effort to make sure that everybody who was in that room doing procedures was using this workflow and closed loop communication. And what you can see here is that after that intervention, there was sort of a August to September workflow window that we have been able to successfully reach our goal. And so we are now getting 75, on average, 75.1% of our lumbar punctures completed in under 15 minutes of propofol infusion on a daily basis. Yep, so that's sort of a general overview of the project. And I think hopefully it was helpful to see how just sort of looking at the root cause of of a problem sometimes can surprise you and result in pretty simple and straightforward interventions to optimize patient experience and overall outcomes. So thank you. I don't know if anyone has any questions or thoughts on the project.
Joanna, I see you online. Do you envision like a panel discussion and open floor for questions? You can type also in the chat box, or yeah, if you want to ask some live questions, you can raise your hand. So feel free to jump in. Yeah.
Yeah, thank you. Thank you, Shelby, for the presentation. I'm right at work and I was trying to get a quiet place where I can unmute and talk. And I compliment you for, and the team for the great work that you're doing. And I'm from Uganda. So for us, I was trying to compare the practices there and what we are currently doing. And I can say that it's quite different, and I really hope that one day we shall also get to a point where we have an anesthesiologist as well for our procedures. But maybe just to share an experience, as currently we are using ketamine, and it's usually us, the nurses, who assist with the procedures. And I would say that this would be great to share with that team, and maybe see if we can also have, if resources allow, have a designated anesthesiologist helping out with that, sedation and procedures. Otherwise, great job to that team.
Thank you. I do think it will be interesting to see. I think as more of this data is coming out about propofol, there actually are parents that are asking about more of that lighter, more sedation and things like ketamine. So who knows, maybe in a few years we'll actually move back more your way as well. I think there are actually some hospitals in the US that do more of a ketamine versed combination as well. So
Great.
yeah.
Yeah, and we welcome any suggestions, questions, sharing from the rest of the members who are online.
I see Masa is raising hand. Masa, can you hear us and you can ask your question, Lee?
Hello. Hello, everyone.
Hello,
Yes,
we can hear.
Yes, thank you so much for the presentation. I really admire it. But for me, in my place, the nurses are doing the work of the anesthesia. So like they will help with the doctor doing the procedure. They will give in our place, we use ketamine and midazolam. So like they will give to the patients together with the doctor. We don't have anesthesia, a special anesthesia doing the sedation for us. That's my own concern.
Yeah, so as I mentioned, we do use the midaz ketamine combination for some of our patients as well. And I think from what I have understood in our patients here that we use it, they generally have tolerated procedures quite well with that combination of medication. Um, and I actually would be interested, to hear more of your experiences using it for the general population, because as I mentioned, I think with the growing concerns about propofol impact on neurocognitive development, and to be honest, rising healthcare costs in the US and using a procedure room like this, that I see a world down the road where practices may change here as well, as long as that sort of ketamine versed combination continues to work well for patients. We use it for a handful of patients here, and most of them seem to do okay with it.
Yeah, maybe some another question I would like to ask, and maybe I would have missed it at the start of the presentation, but I would like to know, were you using the propofol for did you have an age range, or it was for all your pediatric patients, even the older children?
Yeah, so it's for the majority of our patients. We do actually, in conjunction with this, have a study where we are trying to have more patients complete it without propofol use. And I will say, generally speaking, when we get patients to agree to do it, most of them are at the end of it are like, oh, that was way better. They have side effects from anesthesia. They can't eat. They're here all day. A lot of them, have headaches and nausea made worse by the propofol. So we have sort of continued to make an effort for some of our older patients to complete some of the lumbar punctures awake. We do approach patients over the age of 8 to see if it's something that they would be interested in. We do have the luxury of distractions with virtual reality goggles and iPads and things like that, which I do think helps if the patient has something else to focus on. But I would say of the patients that we convinced to do the procedures, honestly, without anything other than a little bit of Medaz orally, and an hour ahead of time, a lot of the times, maybe 80%, I don't have the data in front of me, they do agree to switch to that route completely for logistical ease. So I do think there is a world where we really don't continue to use propofol for the majority of these patients.
Yeah, thank you. Thank you for the response.
Mhm.
Yeah, we also have a question in the chat, and it goes from Jessica. What were the ways you've made to ensure that the new process on sedation during the LP will be sustained in your hospital?
Yeah, that's a great question, because I do think, we get excited, we have these good results, and then yes, over time, people kind of go back to their old habits. So, I think there's going to be a real push to continue to educate our proceduralists. We get a new class of fellows or trainees every July. And so we normally do a big orientation sort of regroup on the procedure room that I lead for them every year. And so I think sort of incorporated into that general education for how the procedure room runs will now be, this is our process, and sort of continuing it with every new hire, new fellow, that this is sort of a requirement for the procedure room. And then keeping the posters up. We kind of place them right in front of the anesthesia's line of sight, and right sort of on the side of a machine where the proceduralist is looking right at it. So continuing to make sure that those signs are up, and making sort of general announcements every couple of months at our weekly we have weekly division meetings here, and continuing to advertise this workflow.
Yeah, thank you for that great response. I'm sure most of us who have done QI really struggle with sustainability, but it's really great when you mention ways how we can try to make sure that the implementation or the projects that we start, or the interventions that we start up, really go a long way in the care for our patients. Yeah. Yeah, we have a hand from Sarah. Maybe Sarah, if you could unmute and let us know.
Hi, this is Sarah, and I have Katie here. We're both from the Children's Hospital of Philadelphia. Thank you for this presentation. At our institution, it's been really important as well to look at reducing anesthesia and reducing also the amount of propofol use. We've actually switched to a predominantly Versed and fentanyl-based, Medaz-Fent regimen for moderate sedation for our leukemia LPs. And we decided to make that our standard for our leukemia patients starting at day 8 of induction, no matter their age. And it's been really successful. I think in the beginning, we definitely had to have providers partner, nursing partner, families partner. And then now that we've been doing this for a number of years, we've actually found a lot of success with just considering it our standard, and then escalating to propofol for patients that aren't able to continue with moderate sedation. And we actually have found that a lot of patients, after trialing moderate sedation with time, sometimes can get down actually to just fentanyl or just Versed. But again, thank you for the presentation. I think it's such an important issue, and it's definitely something we've been very focused on here at the Children's Hospital of Philadelphia, and just wanted to share our current strategy.
I can share our experience here. I'm at the Children's Hospital of Eastern Ontario in Canada, and we have started offering awake LPs for all of our patients. I would say we don't actually offer below the age of 3, but starting at 3, we offer to families. And so it's just done in clinic at the bedside with some EMLA and either a bit of morphine or Ativan beforehand. And so far, so good. People really like it, especially the older kids. They don't have to fast. It's very quick. we just started a few weeks ago, but I would say I don't have the final stats, but the majority have opted for unsedated, and yeah, so we have Child Life that also comes and will distract the kids, and they've been trained in hypnotic communication, so that the kids can be quite relaxed but able to talk and converse throughout the procedure, which really is only 3 minutes when we look at the stats. So yeah, so far so good, and hopefully things will stay like this. So for all our new cases, now we are talking about awake LPs. We usually start in consolidation because we don't want to do it, right away or at day 29 with the bone marrow. And the day 8, usually things are still a bit crazy for them, so we do sedated. But starting consolidation, that's when we start.
Oh, great, thank you. 3 is very impressive. That's really great to hear that that's successful. Do you
Yeah.
have trouble convincing families, or generally people are agreeable if you just say this is what we recommend?
We offer, so we really just give the choice, and that's how we say it. We offer, you have the choice. You can go back to sedated if you want, and we have a pamphlet that explains all the steps, how it's going to be done, in very child language, so that parents can actually share with their kid without saying, hey, we're gonna poke you in the back, kind of thing. So so I would say the most family don't have to be convinced, and we don't want to convince them. We really want them to be willing, because that's also key to the success of the procedure, I find. But the majority, if not all of them, are very willing to at least try. And so far, we haven't really had to go. There's one patient we had to go back to sedated, but I think we'll be able to go back to unsedated, because that day she was freaking out even before the LP for other reasons. And so it was just not a good time. So we didn't even try it, actually. We just booked for sedated. But that's the only one so far that has not worked. And she was 3, so, and nonverbal.
Wow. I think those are really great experiences. And I think it was Sarah who shared the fact that they're involving a multidisciplinary or different stakeholders, the caregivers, the nurses, the doctors, and it's very important to enable the success, or to ensure the success of our quality improvement projects. Yeah, we welcome more experiences, more questions. And if anyone else has any questions for Shelby, or they need clarification, or want to know more about their quality improvement project, you're welcome to unmute or share your question in the chat box. Okay, if we do not have any other supplementations, I would like to appreciate Shelby. Thank you very much for sharing with us your quality improvement project. I'm sure all of us have picked a thing or two from on there. And thank you everyone for attending. And those that have shared their experiences or their practices at their hospitals with us, thank you very much as well. All right, have a great rest of your day, unless Shelby has any last words for us.
No, I just wanted to say thank you as well for having me, and thank you to everyone for sharing your experiences. It looks like there's still a lot more work that we can do here to reduce propofol
Mhm.
exposure for our patients. So it's been great to hear that others have had success with other methods. So thank you.
Yeah, yeah. All right. Thank you. Have a great rest of your day.
Thank you. Have a nice rest of the day.